Hi, I'm Craig, and I'm the co-host of the MQ Open Mind podcast. On behalf of Professor Rory O'Connor and myself, thank you so much for watching Season 3. We hope you were able to gain a further insight into the world of mental health research, whilst understanding more about yourself and those around you. This 5th of July marks the third Research Appreciation Day, a day started by us at MQ to celebrate the hard work of health researchers from all disciplines. For this special episode of Open Mind, and since this year's theme is careers in research, here are our esteemed guests explaining how they got their start in research. Open Mind will return in the following weeks, and we hope to see you again for more lived experience stories and more mental health research. Thank you. First up, we hear from Professor David Nutt, Edmund J. Safra, Professor of Neuropsychopharmacology and Head of the Psychedelics Research Centre at Imperial College London. David shares how he first entered the field and what sparked his journey into this controversial area.
So, David, I was doing a bit of reading around you to your journey, and I'll be really curious to hear about your journey. So, I think it's gone from Bristol, Cambridge, Oxford. Then you did Bethesda and outside Washington, and back then to Bristol, and then to Imperial. Mm-hmm. So, can you maybe tell us a bit about your journey then, and what we're interested in the podcast is where your sort of interest in sort of mental health and psychiatry came, and then obviously the work you've done since.
I could point you to my autobiography, but it's not uncut. You can read all about it. But very, very brief précis. Fascinated about science when I was 10 at junior school, when they showed us how you detected the power of atmospheric pressure. Became fascinated by the mind. I was about 16, 17, starting my A-levels, listening to people like Gray Walter talk about EEGs and how you can measure things going on in the brain. Went to university to do natural sciences at Cambridge, but just realized before I turned up I would rather do medicine than zoology. So I switched to medicine because it was easier to study what I wanted to study, which was humans. Trained in medicine at Guy's Hospital and St. Mary's Hospital. And then went back into research where I've been ever since. Started off doing neurology, got bored with that, moved to psychiatry. That's infinitely fascinating. And, you never saturate your knowledge base with psychiatry. And gravitated towards pharmacology because the explanatory power of neurotransmitters and receptors is just overwhelming. I was trained at Cambridge by people like Jimmy Mitchell, who discovered GABA as a neurotransmitter, and Les Iverson, who discovered noradrenaline uptake sites. So I've always been fascinated by the explanatory power and, of course, then subsequently the clinical utility of drugs. And that's what I've done ever since. And my sort of claim to fame, I think, is that I've probably given more different kinds of drugs, particularly brain-acting drugs, particularly illegal drugs, to humans than anyone alive, maybe ever. No one's ever challenged me on that anyway.
Well, I suppose it's a claim to fame of some degree, certainly. But I think from what always has impressed me in the work you've done is everything you do is obviously evident. It's in the pursuit of science and knowledge and therapeutic benefit, but it's all grounded in. So you made that sort of flippant remark about giving drugs to lots of people, but it is to build the evidence base. And I suppose maybe that brings me on to sort of the next sort of question, which is like there is so much scaremongering. I don't know if scaremongering is the correct term, but a lot of concern about some of the work that you and your colleagues have been involved in over the years. And I suppose it's maybe to get your sense on, well, why do we think it has been the sort of risks versus harms versus benefits have been sort of arguably taken out of proportion?
Well, that's another book. It's called Drugs Without the Hot Air. It's because drug policy is largely driven by political expediency, which goes back, interestingly, right back to the turn of the last century, the Hague Convention, when pharmaceutical companies realized that they could patent primitive derivatives of endogenous natural compounds. They could turn morphine into codeine or heroin and get patents and control the market. So they wanted to eliminate the natural products. So that was the beginning of the whole sort of IP control. And then, of course, the prohibition of alcohol in America and Scandinavia in the 1920s, which led to major problems that, of course, like the mafia, the rise of the mafia, which led to the abolition of prohibition in 1933. But at the same time, it led to the growth of the Drug Enforcement Agency in the States and the repeal of alcohol prohibition was going to make 335,000 people unemployed. So they had to come up with some other drug to be worried about. So they invented the fears of cannabis, called it marijuana. And then basically the war on drugs has been perpetuated through the need to keep those people employed and the need to get particularly Republican politicians elected, although I have to say the Democrats have also been pretty reprehensible. So American policy of using drugs as a way of getting votes and the war on drugs, particularly from Nixon, and the fact that all our drug laws have been made at the behest of the Americans means, and as have all the drug laws around the world in the UN and the WHO. So the bottom line is drug policies are politically and economically driven rather than scientifically driven. And that is both outrageous, immoral, and also extremely destructive because there are many drugs that are really useful. Drugs like medical cannabis, which have been around for 4 to 5 millennia, drugs like psychedelics, which were proving really very effective in the 50s and 60s, they've been denied to the public, to the sick public for the last 50 years, which is absolutely, totally. It's the worst censorship of research in the history of the world. And I've rebelled against that. I think if one thing science should do is at the very least challenge those kind of misperceptions and political decisions.
But then in that context then, so in terms of trying to get funding for your research, I know, so there, because obviously the challenge then is when you're funded by pharmaceutical companies, there's obviously risks and challenges there in terms of access to data and whatever vested interest. So how have you dealt with that bit of it? And then also trying to get funding from other organizations independent of drug companies?
We've taken a sort of multi-track approach. So one of the things I've got quite good at is writing grants to explore the harms of drugs. And of course, that requires studying drugs. So we've done an enormous amount of work, particularly using brain imaging to explore questions like the nature of addiction, the nature of alcohol addiction versus heroin addiction versus cocaine addiction. So that's given us the framework of the brain research. But to study more challenging drugs, particularly drugs like MDMA and psychedelics, we've largely gone to philanthropists because particularly in America, there are quite a lot of very rich people who believe, possibly correctly, that the use of psychedelics is why they became visionaries and very successful. And Silicon Valley is full of people who've made ridiculous amounts of money and are very sympathetic to the idea that psychedelics were part of that. And, when you think, I'm talking to you on my AirBook Mac and Steve Jobs, Steve Jobs built the biggest company the world's ever known based on having a trip in which he realized it was possible to fuse art and computers. And
I didn't hear that story before.
Next, we're joined by Professor Louise Arsenal, Professor of Development Psychology at King's College London. In this clip, Louise highlights the value of cross-collaboration and health data and opens up about why she chose to focus on mental health over physical health. So
maybe then if we can go back to where, the beginning, which is, so can you tell us a bit about, I know you're Canadian and you studied in Montreal, but it'd be great to maybe just tell us a bit about your journey in mental health research. What brought you into the area, what interests you, and sort of how you got to coming to King's a few years ago, some years ago.
Wow. Okay. That is an interesting question. So yes, I am from Montreal, so I'm French Canadian. You can hear that in my strange accent. But I studied in psychoeducation. So originally I'm trained, to work with people with mental health conditions. And that was my undergraduate kind of degree. And as I kind of started working, I realized early on that I felt I didn't have that much to offer, to the profession in some ways. And I rather kind of continue to study. So maybe that would be my better way of helping, people who suffer from mental health conditions. So I decided to do a PhD in biomedical sciences, which is some kind of a strange umbrella. In the end, as part of that PhD, I really learned how to conduct research, do research. And actually, I started doing research by collecting data as part of a longitudinal data sets. That was my entry into the world of research and mental health research. And then I got kind of postdoc funding, which kind of brought me to move to the UK. And actually, that was 25 years ago last week. So I've celebrated my 25th anniversary last week. Isn't that amazing?
Congratulations. Congratulations.
Thank you. Very pleased about that, actually. So that is what brought me into mental health. I think I always wanted to engage in a support relationship. And I thought that dealing with physical health was too concrete. It was kind of, I didn't want to work with arms or skin or, I wanted to work with something which was more abstract.
I'm just curious how you've pointed out you didn't want to work with arms or skin. No other parts of the anatomy? Or...
No. Brain. Yeah, I was thinking about which part can I say without being too controversial. So I thought that the mind was kind of something more abstract that was a big challenge. And so, yeah, that was where the interest in mental health, I think somehow something which was more abstract, but, still related to this support relationship, to help people overcome, kind of challenges. So that is what brought me into it. And then, I think that realized quickly on my lack of knowledge and wanted to understand better.
So just a quick question just on the the longitudinal data set stuff.
Yeah.
So when you were in Montreal, did you be part of a group establishing a longitudinal data set?
Yeah.
Right.
So that is even after my degree, I was kind of looking for a summer job, and someone who is working in our research group back in Montreal, they asked me, they said, would you mind kind of coordinating this kind of lab that we're setting up for the summer, which was part of a longitudinal study? And I said, yeah, fine, okay, yeah, we'll do it. I didn't have that much experience, but I kind of led a team. I think that we were 6 research workers, and we had 5 kids with conduct problems coming every day of the summer, and we had a whole series of tests during the day. So I did that for a whole summer, and at the end of the summer, the person who became my PhD advisor said to me, we want to keep you, but as a PhD student. So suddenly
it was Tremblay.
Yeah, Richard Tremblay, back in Montreal. So that is where everything started, basically. And I remember very precisely the meeting that we had where he asked me, he said, well, I would want you to continue and do a PhD. And I was so surprised by this. I was kind of going, I don't have any talent. Why do you ask me? I said, the only merit that I have is to work really hard when I want something. And he said to me, that's good enough for me.
Oh, that's obviously that sort of imposter syndrome that we all experience, but that's a brilliant opportunity then.
Absolutely. But I really felt that I started doing research by collecting data. And 25 years later, I am still involved in research where data collection is at the core.
Yeah, the core.
Yeah. And I think that is defining really my career, the importance of data collection in doing research.
Well, also really good quality data collection, I think, is at the heart of it.
Absolutely. Yeah. So this is the foundation for everything. And quite often, which is a shame, is that researchers see that as just a step. We just need to collect data. They don't spend that much time recruiting the right people to collect the data. They don't think very much about what do we need to collect. And that's such a shame, because this is the foundation for everything in research. So I am a true believer that data collections are really, really important, and that we are not making the most out of the data that is collected.
So then do you wonder, and thinking about the training that we do in the UK or elsewhere, I wonder then, do you think that we don't prioritize the importance of good data collection, and that it's more seen as a means to an end rather than being a fundamental skill and endeavor in itself?
I think that maybe the training should be, that's an important question. I think that we do not necessarily want to fund just anybody to collect data, because I think it does require skills and thinking and preparation. So funding kind of quick data collection for me is not such a good investment, but there are people who do that beautifully, that are very experienced, that have a whole infrastructure behind them. So I think that we absolutely need to kind of support those infrastructure and researchers. I think that it is important for people to appreciate the value of good quality data, but I think also very importantly, it is important that training focus on how to use those data.
Yeah.
So I think that we need to kind of support young people in acquiring skills to be able to, use the data, analyze the data. And I'm not sure whether everybody needs to collect data because we have so much data already.
Yeah. And we'll come back to the data issue shortly when we focus in on the landscaping report. So just to go back in terms of your sort of history, your career. So in that early work, I think you mentioned you were in Montreal still. You were assessing ADHD. So your interest in mental health was apparent then, and then you've just continued with that.
Yeah, absolutely. So I studied kind of more conduct problems when I was doing my PhD, and I did work on trying to understand the early origins of aggressive behavior. And I thought that I had a connection with people who are more aggressive. So that was something kind of really interesting for me. But then when I moved to London, then I kind of joined a different longitudinal kind of data, kind of group doing longitudinal data. And I joined a very well-established group based in New Zealand. But then I also joined a group that was establishing a new longitudinal data set. So it was very interesting for me to be able to capitalize on a very well-established group, but also kind of being part of starting a new kind of longitudinal data.
So the established one was the Dunedin.
Yeah.
The Dunedin cohort.
And
so you were involved in that from London.
Yeah, absolutely. I went to Dunedin to spend a bit of time to work with the team and to understand the context, which I think is really, really important, and met kind of policymakers. And, I was kind of meeting them, sharing the results that I had. So that was very important to me. But I was based in London. And then we were starting the ERIS, the Environmental Risk Longitudinal Twin Study in the UK. So I was working with Professor Moffat and Caspi, and we kind of set it up. So I was involved in data collection, as part of that beautiful cohort study as well. So
So this is maybe a bit of an unfair question, flagging that now. But what do you think has been like the one or two most important findings that you've been involved in publishing related to any of those data sets?
Oh my God.
I said it was unfair. I mean, the most impactful maybe.
Okay. Well, I think that working with the Dunedin study was absolutely amazing because it's such a well-established longitudinal study, which had so much to offer somehow. And that really kind of kicked me towards more mental health condition rather than aggressive behaviors. So that was really important for me. But then I started working with the e-risk study, and then I developed a program of research on bullying victimization.
Yeah.
And for me, that was really important because while I was not necessarily interested by a specific condition, I was very much interested by risk factors and testing those risk factors and to what extent do they really contribute to the development of mental health problems. And working with a twin study was very key because it allowed us to control for genetic confounders, which I couldn't find in any other cohort study before. So for me, that was really key. And I could develop really a whole program of research looking at how bullying victimization can influence mental health, but also physical health. So that was really a data set that offered me a platform to develop research on this. But then at some point I moved on and I worked with another longitudinal data set, and that would be the National Child Development Study, so the 1958 cohort, which allowed us to examine whether being bullied in childhood could have long-term impact. And to me, that was absolutely key in the development of my career for different ways, but it was one of the most impactful paper that we've published, looking at the long-term outcome of being bullied. And I like that paper for various reasons, but one of them, it was published in one of the most impactful journals, so the American Journal of Psychiatry, and it made the cover. So for me, it was really important that suddenly bullying, which was dismissed, for many years as, oh, it's part of life, it's not important. Suddenly it was the cover of the American Journal of Psychiatry. And we did, it was throughout the whole kind of newspapers and the media outlets when it was published. So did the Today program and, lots of different interviews. But the most important thing was that I thought that in terms of impact, that paper kind of ticked all the boxes, because the journal was happy because we were on the media. My dean was happy because, we were in one of the top journal. So I was kind of going, oh, that's great. And after kind of coming back from the BBC, I went back to my office, opened my computer, turned on my computer, and then I look at my emails, and then suddenly I kind of realized that I had lots of emails from people from the public kind of saying to me, hey, I heard you this morning in the news, and what you describe is my life. Yeah. And to me, that was impact. So, and it's a shame because in some ways, this is not recorded anywhere in, the importance of research and what we do. But for me, that was the first time I was doing research involving adults, because before I always worked with children and teenagers. But adults, they can kind of reach out to you and they can tell you what they think. And suddenly I had this opportunity, and so many people kind of engage with me, kind of saying, this is really important, this is how I feel. Or they would say, I'm doing okay, but I will never forget that I was bullied when I was a kid. And to me, that was one of the most important paper, because it made me realize what we can do with research.
Yeah, well, absolutely. I think that is really powerful, and how our research can affect people's lives, and hopefully for the better. But I think, and I suppose with the ref, we are getting better at trying to recognize that impact, of course.
To explore young people's mental well-being, we spoke with academic psychologist and author, Dr. Lucy Fox. Lucy reflects on her decision to pivot from a career in medicine to one in psychology, and what inspired that change.
We're really excited. I'm familiar with your work, both your popular science book, which came out in 2021, which we'll talk about shortly, but also the fantastic research you do as well. So what I'd be keen to maybe to begin with is tell us a bit about your journey in sort of mental health research, and more broadly, and we all have a different interest in mental health. Do you want to tell us a bit about your story in terms of where your interest in mental health came from?
Yeah, it's a good question. Depending how far back you go, I was originally going to do medicine when I was doing my GCSEs, and took psychology on a bit of a whim as an AS level subject, and then realised I liked it much better, just found it fascinating. So I switched and decided to apply for psychology at university instead. And then when I was at university, I just think the mental health side of it is fascinating. I mean, I think it's interesting understanding when psychology goes wrong or sort of stops serving us. So I think that, it's not a particularly original thing for an undergraduate, but I was always very interested in the clinical side of it. And I had some experience of my own problems around that time, but I don't think that really made me interested in this. I think I was interested in this already. I just think it's fascinating.
Yeah, no, it is. And what's really interesting, I think, is how our attitudes towards mental health and mental illness have changed over the years. And I know you talk a lot about this in your book, what mental illness really is and what it isn't. And I know, obviously, at the start of the book, you talk about your own experiences, which you alluded to. And I think, well, it's a powerful personal narrative, but also powerful, and I think in illustrating the way we talk about mental health more broadly. So do you want to tell us a bit about how you started the book and that the experience of mental health problems yourself?
It's funny, and I debated whether to put it in the book or not, but really I wanted to include it in the book because I wanted the reader to know that I wasn't just coming at this purely from an academic perspective. So even though I don't particularly find it easy to talk about, I felt like I sort of had a responsibility to the reader to tell them that I you know, I'm interested in this academically, but I also really know how it feels when you're unwell and how bad that is. And I think that gives me a little bit more license to make some of the criticisms that I make about the way we talk about mental health. So that's why I included it. But yeah, it made for a good, structurally a good opening in the book to say that I had my own experience of depression towards the end of university, and that it sort of just so happened to coincide with the beginning of this transformation in the way we talk about mental health.
Mhm.
Because when it happened to me, which wasn't really all that long ago, it was in 2008, no one talked about it. You know, it was a sort of deep secret. And, you know, I would see doctors and things and they'd say, this is incredibly common. And I would think, yeah, it's not meaningful that you say that, because everywhere I look, no one else appears to be having these problems. And so just by coincidence, that my own experience sort of happened at what I see as a start of a shift. And in the subsequent years, there was suddenly this sort of explosion in people talking about mental health in a different way.
No, I agree with that in terms of timeline, because as somebody who's worked in this area for quite a while, from the mid-90s, well, through to now, obviously, and continuing. But I think probably my sense as well, I don't know if 2008, I don't know if it's precisely then, but certainly in the first 10 years, I would say, of working in this area, and a lot of the work I do is obviously the most extreme end of devastation from mental health or social crisis or social problems. But definitely there's something happened at that. And I don't know if it's a post-millennium thing. I don't know what it was, or where some important people in the public eye starting to talk about it more or whatever. It's hard. It is really hard. But actually, can I maybe slightly sidetrack then actually on that? Because you published a recent paper in like New Ideas in Psychology. And I suppose it relates a bit to this explosion idea of talking about it. And maybe what is the potential impacts about, is it really that there's been an increase in mental health problems? I know this is at the crux of a lot of your thinking, or is it that there has been an increase, or that we're talking about it, it's normalized? So maybe do you want to tell us a bit? I know you've written so eloquently about this, but also I really like the recent paper you've talked about this in a more empirical way, I would say.
Thank you. Yeah, it's interesting to say about writing about it eloquently, because obviously it isn't. My writing and talking about it is the end point of a lot of thinking about it, where it's very messy to try and unpack it all. But yeah, that paper that you mentioned, where we talk about the prevalence inflation hypothesis, was, you know, I'd written about it in the book, and I talked about it an awful lot in interviews, and then I really wanted, and written about it in, you know, newspapers and magazines, and I really wanted to formalize it in an academic publication. So that was that paper that you're talking about, where I write that there's no one explanation. There will never be one explanation for why more people are reporting mental health problems now. But I'm, along with my colleague Jack Andrews, we're presenting the possibility that actually the way we're talking about it is one factor that's contributing to the increase in problems that we're seeing. And we talk about that as sort of two possible mechanisms. So one of them a good thing and one of them not so good. So the first one is that it's really quite obvious, but it's if you encourage people to talk more about mental health and you run lots of campaigns and you destigmatize mental health problems, then of course some people who might previously not have reported their mental health problems are now coming forward. They're going to the GP, they're, you know, ticking the elevated box on questionnaires, for example. So actually the sort of underlying rate hasn't increased. You know, these people were depressed or anxious or whatever before. It's just that they now feel able to report that that's what they're feeling. So the net result is still that it will look like things are getting worse, but they haven't necessarily. And actually that mechanism is a good thing. Like, that was the whole point of telling people to talk more about this stuff. Then the sort of second route, which I'm particularly interested in, is the possibility that this well-intended plan to talk more about it is actually sort of backfired, in that it's encouraged people to conceptualize milder, sort of more common everyday negative, sometimes, you know, extremely negative experiences as being mental health problems, and then reporting them as such, and, you know, telling their GP about it, which is in itself could sort of misrepresent how many people have mental health problems. But then I think it could actually even itself lead to an increase if it leads to these problems in a kind of self-fulfilling manner. So I'm very interested in the possibility that if you frame your problem, your anxiety as an anxiety problem or an anxiety disorder, could you actually bring that anxiety into being or increase it? So there's those two routes. One of them's a good thing, one of them is more problematic. And I really want to probably spend a lot of my career trying to unpack and sort of empirically investigate whether those things are happening.
No, that's really fascinating, Lucy. And I mean, in particular, when I think about those two explanations or potential explanations, the second one is clearly will be bidirectional. Both of them are obviously in some ways bidirectional, but I think it's a challenge to see how you would unpack that in an empirical way. But I wonder, though, going back to the point about, so my sense is I think that definitely there's, and again, it's intuitive. So it's not scientific in that way. I agree that I think that certainly a certain percentage of the increased reporting is linked to, in some ways, increased awareness. But I also get a sense, for example, in the work that we do in sort of suicide and self-harm, is that there has been, if you triangulate all the different data sources with all its implicit biases, I do think that suicidal behavior, not suicide globally, I'm talking, for example, in the UK or the United States context, that they have increased. Those rates have increased in recent years.
In another episode, Regis Professor of Psychiatry at King's College London, Professor Sir Simon Resley, offers his unique perspective on the NHS. Here, Simon shares candid stories from his early days in psychiatry from back in the 1980s.
So Simon, I know quite a bit about you. Obviously, I've known you on and off over a number of years. And so I'm just really fascinated about your journey in sort of mental health science, so to speak. And I know, obviously, you're born in Sheffield. Mm-hmm. So maybe just take us on a bit of that journey, because we're always trying to start the podcast with trying to situate our guest into their sort of life history, so to speak.
Yeah, I mean, fair enough. I mean, I come from an arts background, if anything, not a science background. My mother was a musician and my father was a language teacher. And I was much better on the kind of arts humanities side at school. And then for reasons that I still can't remember, when I was 15, I suddenly said I'd like to be a doctor. And I don't know why. There were no doctors in the family at all. And my parents were slightly, I wouldn't say appalled, but a bit surprised. But so I pursued that, got into medical school. And then I was the one person in the year who didn't do integrated science degree. I did history of art. You could probably have guessed at that point that I might end up in psychiatry, but I hadn't guessed that. But, an observer of the scene might have said that. And it was because it was very well taught. I found it very interesting. And as I went through kind of the early stages of medical career, doing MRCP and things like that, it wasn't that I was bored, because I wasn't, and I had a great time. But I found the kind of things that I was still reading was still kind of psychiatry books and things like that. And then someone said, well, listen, you might as well bite the bullet and go to the Maudsley, which I did, got in. And I had no interest in research at all. So I basically lied to the dean, who was a fellow called Robin Murray, you've probably heard of.
Yeah.
And But then, once you were there, you couldn't help, the peer pressure was intense and the pressure from the consultants was intense. So I finally, had to start doing some research. And then I just got the bug. And then the big turning point was getting a Wellcome Training Fellowship in epidemiology. Because if I hadn't got that, then it would have all come to nothing. But I did get that. And then everything fell into place and I knew what I wanted to do. And been doing it pretty much ever since, with some breaks to do other things. But I still enjoy it and get the buzz after all those years. But it was a decision to go into psychiatry and then getting the Wellcome Fellowship. And without the Wellcome, nothing would have happened.
And what was that? That was the 1980s, was it?
Oh, God, yes. Yes, it was. Long time ago. Yeah, I think I got the fellowship in 88, I think, something like that.
So just as a slight aside, and Simon, reflecting then on, because you've obviously ever since that time been involved in some shape or form on mental health research. So this is maybe a wee bit unfair of a question, but reflecting back now, do you think it's, because obviously psychiatry is a profession, as an outsider looking in, not as a non-psychiatrist, it looks like the profession's flourishing and, as an outsider looking in. Now, my sense of in the 80s and early 90s, perhaps, that was less the case. Is that true?
I think that's true. I mean, remember, I was lucky that the Maudsley was about the only place in UK which was competitive. to get in. I think maybe Edinburgh, Oxford were as well, but certainly we were the place in the same way in those days. Great Ormond Street for peds, and Brompton for cardio, and the Marsden for cancer. All of them London, and all of them were regarded as the kind of first among equals. So it seemed pretty healthy there. The people, you were working for were some of the giants of the stage, and very interesting people, even if sometimes very difficult. So it didn't feel that. But as soon as you started to get around a bit more and you realize that, yes, and as I got into postgraduate training and running a huge scheme, the multi scheme, you realize that it was a difficult profession. And was failing in recruitment. We couldn't fill our posts, and because we couldn't fill our posts, we couldn't make bids for more posts because the powers that be say, well, when you've filled your post you've got, we might talk about more, but until then, you can piss off. and in fact, the reason why I kind of didn't say take a career break, but that I did end up becoming president of the Royal College, was solely and completely on the issue of recruitment. That if we couldn't stop and then reverse the decline in numbers, the profession wasn't going anywhere. And over a course of really 10 years and probably 4 presidents, we did do that. And of course, there were lots of other things as well. There were changes in society, changes in the people going to medical school and all sorts of things. But nevertheless, we did play our part. But you're right. And it was certainly unfashionable. And when I said, I think I want to be a psychiatrist, when I got offered a PhD in liver studies at Newcastle, where I was working, and people did kind of take a step back, and then they would either laugh or they would say something like oh, well, you're too good for that, which actually is a veiled insult. And then and all that stuff, and we had the whole lot, and one of my early jobs was at Queen Square, the National Hospital of Neurology, which had just changed its name from nervous diseases because it was too psychiatric. Then they went to neurology, and they would come up to you, and all these hundreds of neurologists, and say, well, you seem like a decent enough chap, because that's how they speak. And you seem like a decent enough chap. I can't understand why you'd want to do psychiatry. None of your patients ever get better. And then you're thinking, this is a neurology hospital where virtually nobody got better. So there are all these prejudices that you have to embrace, really. And I think many of them still exist, if I'm being honest with you, in not in society, but some of the people still with some of the more antediluvian views are our fellow professionals in medicine and professions allied to medicine. Yeah.
And so, but in terms of just going back to the reversing the decline in numbers, so you mentioned changes in society and maybe the people who went to do psychiatry. But so, what are there specific things you did as a college to arrest that or turn that around?
Yes, I think there were. I mean, I think the first thing was that we had no communications unit at all. We had an answer phone. Basically, we had one press officer and an answer phone to deal with media, which meant that lots of other organizations were always doing the media we should have been doing about mental health, mental illness, things like that. And I thought, well, this is ridiculous. We should be talking on these issues. So we made a huge investment and went from 1 to 25 people in the comms unit. And we saw, I think it was a 500% increase in our media reach, Hansard numbers, all the various metrics that you have, which was pretty much about to happen if you put that investment in, but we did. Yeah. And the second thing was we didn't want to send a message of how rubbish everything is and how nobody likes us. And because, you can't, if you go around saying that, no one's going to want to do the job. And,
it's not really inspirational, is it?
No, it's not. No. And telling stories, which we were good at. Also campaigning, which we got good at. And by this time got much, much better relations with organizations such as Mind. And there was a kind of collective group of the kind of main forces in mental health, with Mind, with us, Centre for Mental Health, like that, came together. And when we all kind of played as a pack, we were quite a powerful lobby, actually. But it was more and more just, projecting how interesting this was, how it didn't suit everybody. They're like people who like running at work should do A&E or cardiology or things like that. But we're more, we take our time, patience, both being patient and having patience, and getting to actually know people rather better. And the one word I would never use is holistic, because I hate it. But actually, that is what we were promoting. And we sometimes would say, look, we're like medicine plus. We have all the best bits. We also do other things as well. And of course, pushing the research agenda was important, that we're going places, there's more to be done. But I think it was that, we wanted people either who were intellectually inspired by neuroscience, and because this is where the next Nobel Prize is going to come from. Unfortunately, it hasn't yet, but I still think it will. Or who actually do like to spend time and get to know people, to understand families, to understand society. So it was those two twin recruitment things we did. Got money from Sainsbury's to revolutionize, change the curriculum, make it more neuroscience. And but the whole thing was just pushing a more positive image. And at the same time, I have to say, things like the Bonkers Bruno's headline and things like that really played into that landscape, and saying, look, that's unacceptable. And
for those who don't know, that was a headline on the Sun newspaper, I think, in the 90s.
Yes. Yeah.
About Frank Bruno, the ex-boxer.
And so there was work the Samaritans were doing on suicide reporting, but just the general thing about being more respectful towards mental disorders. And that did change. I was lucky I'd been a journalist. I used to write columns for the Times, and I also discovered I had quite a penchant for live radio, and I really enjoyed that. And too many doctors get really, intimidated by media and say, oh, well, you can't do that. You can't do that. Actually, it's great fun. And so I did quite a lot of that and enjoyed it a lot. So it was a whole sequence of things. And the other thing to be clear is that my successors very much carried this along, and we had a coherent policy of how we were going to do it right through till when we finally, became competitive across the country, which was 3 years ago, I think.
Right. Okay.
Well, I think we're now more popular than surgery, actually. Yeah. And at the same time, the same thing was happening. Clinical psychology was becoming incredibly popular.
Yeah.
And I just said, all those, when you talk to schools, people, I want to be a psychologist. Said, well, why don't you do psychiatry? You'll find it's a lot easier, and you'll know whether you've made it a lot quicker. Yeah.
But that's interesting, though, Simon. So, that, because really a lot of those changes are so recent, and that's a bit, which is, you reflect on it as, as a profession, obviously we're not that, or medical or mental health science, we're 100 odd years old, broadly speaking, depending on how you define it.
Yeah, that's true.
But these changes are really recent.
We also sat down with Dr. Sian Williams, BBC broadcaster, author and counselling psychologist, to talk about the mental health of war correspondents. Sian reveals what led her to change from a high-profile career in broadcasting to one in psychology.
But let's get going, Sian. This is about you, not about me or Craig. So, no, I'm really genuinely fascinated. I've been following your career for many years, and I followed the transition into psychology. But can we maybe go right back to the beginning, before your pre-interest in, or before you were interested in mental health? But tell us about your early life and career, and how you got into journalism, first of all.
Oh, gosh. So my parents, one was a nurse and worked in intensive care, and my mother, and my father was a journalist. And I thought, while my mum wanted me to work for the NHS, because we're really sort of steeped in that. So we've got a lot of doctors and nurses in our family, and I think it's now 6 generations of my family have worked in healthcare and the NHS, and they were in healthcare before the NHS started. She wanted me to go into the NHS, and I just thought, I can't even watch an episode of Casualty or Holby City without having a little wobble when they get the needles out. So nursing or being a doctor is not going to work for me. My dad was a journalist, and that looked incredibly exciting because the radio was always on, tuned to news. We had all the newspapers. He was being called in the old days when you didn't have mobile phones and you had a phone attached to the wall, or one of the big dial phones. It used to ring, and every time it used to ring, I used to think, we're going to lose him now because there's a job he's going to be going off to. But it did seem really exciting. He didn't want me to become a journalist, and he said, do not become a journalist, and whatever you do, don't join the BBC. And I did.
You clearly listened to that advice.
I know. Exactly. It just it was the only career really I wanted to do at that time. I liked reading, I liked writing, I was interested in the news. I'd gone to America to study critical journalistic writing. I was very lucky to have won a place in America to study at an American university for a while. And it seemed like a natural choice for me. So I kind of badgered and persisted and got into the BBC, and then spent 37 years, I think it is now. I'm back at the BBC doing radio, and I started at the BBC doing radio all those years ago in the late 80s. And then I guess I got interested in the way our minds work. We were often sent as journalists to very traumatic events. No, that's the stuff of news, isn't it? Mm-hmm. Disasters, and you're parachuted into what's often the worst day of somebody's life. Mm-hmm. And I was introduced to that very early. As soon as I came out of university and went to local radio, I reported on the Hillsborough disaster. I was working in Liverpool at the time. And I think became very aware of what it must be like to be caught up in an event not of your choosing, to be exposed to something that will change the rest of your life. Mm. Yeah. And as a very naive 20-something-year-old, 21-year-old, I probably asked all the wrong questions. Yeah, but I did think to myself, gosh, how are these people going to manage? When I leave, I've got their stories, and there's a huge responsibility with carrying those stories. But what happens to their life when we've all gone, when the story starts inevitably, as they always do, dropping down the running order? And how do they manage that experience? How do they live with that experience? And then throughout my career, I was sort of drawn back to that understanding. What goes on in the brain? How can we best support people, either those who are caught up in that event or those witnessing that event, like journalists? How can we best support people to manage that stuff well? And that took me into psychology.
So you're maybe 25 years into your broadcasting career when you sort of actively then started retraining. Is that about right? I think it's about 2012 maybe, or something like that. Then
well, I did a science master's, which was quite theoretically based in psychology at that stage. Huh? Previous to that, I had trained as a trauma assessor. So very simply identifying potential red flags in some of my colleagues who were coming back from difficult assignments. So I'd recognized in myself that there were some times when I would get back from an assignment, I wouldn't be able to talk about it with anyone. I felt quite guilty that I was leaving and leaving all these people behind, that my help, as it were, was quite limited to showing the audience the horror, but then I could always go back to my family and my comfortable life. And I was aware that other journalists similarly who had been immersed in tragedy, or it might be a really difficult court case on child abuse, or it might be at a natural disaster or a terrorist attack, that they'd been immersed in this stuff to report to the public what had happened. And then when they came away from it, sometimes it was hard to process. So I trained as a trauma assessor many years ago, and then I did a master's while I was still at the BBC. And then I went on to do a professional doctorate in counselling psychology while I was working at Channel 5 as a newsreader. Yeah.
We'll come back to the doctorate and stuff. I'm just still curious about the trauma account. So was that off your own initiative, or was that a BBC thing that as an organisation they were keen to support journalists better, or was that?
So I knew that there was some support being offered, but was also aware that the culture of journalism often prevented journalists accessing it. So things like employee assistance helplines, things like just reaching out to a peer support network, or those things existed, but they didn't seem to be accessed very often. And I wondered why. But when I could see my own colleagues were having some difficulty. And there was something being offered at the time called trauma risk in management, which was designed, you probably heard about it, by Professor Neil Greenberg, who was in the Marines, and a psychiatrist, works at King's. And I contacted him and said, are you running this at the BBC? And he said, we're just starting to do a few training courses. And I went on that training course and learnt what to look for, not to ask questions that will go deep into any trauma, not to reactivate any trauma, not to make anything too emotional, but just to ask enough factual questions so that if somebody was struggling with sleep, or they weren't communicating with their family, or they were having other kinds of difficulty, that you would just go, oh, okay, I'm going to come back to you in a few months' time, and then back to you again, and make sure that I'm directing you to the pathways for help. So yeah, that was where it started. 2005, I think, 2006 maybe.
Yeah, but you seem to have been really psychologically minded from the such early days, even before that in your career. So the thinking of the impact on yourself and the viewer and your colleagues.
Well,
these difficult and challenging situations.
Yeah, and I wonder whether that actually came from my mum's side of the family, because she was a nurse and because she was a very caring woman, and she cared for her patients psychologically as well as physically. And I could see that work could take a toll on her when she lost patients, and she could be very low after working with people that she couldn't help. And I think that brought an awareness of the impact that a caring profession can have on you, and any job can have on you when you are immersed or exposed to other people's grief or illness or trauma. And so perhaps I was more alert to that when I became a journalist and saw it from a different perspective.
Yeah.
And thinking, what goes on in the mind of those experiencing traumatic events? How can we best protect them if we are given responsibility for their stories? And how can we best protect ourselves when we're witnessing those stories so that we continue to tell them well?
I suppose what you just said there just reminds me of, I suppose, what you do in the Radio 4 program now, the life-changing program, in a way. That's why it's just what you said about people telling their stories, or, well, in a way which is acknowledging, well, there's some amazing stories of people's lives that you cover in that. And I'm also thinking you did, and then at Channel 5, you also had that mental health slot as well, didn't you?
Yeah.
You're doing a lot. So I mean, everything, I suppose, over the last number of years has it psychology in some way at its core. And that's obviously a deliberate thing, obviously.
Yes, it is a deliberate thing. I mean, we're all talking about mental health more, and that can only be a good thing, obviously. I think it can be quite hard to represent that. There are some very good celebrity documentaries where somebody has a mental health issue, and they use that to explore that issue, and that brings people to it. It can be hard to show, I guess. It's easier to show physical illness on the telly or radio than it is a mental health illness or difficulty, which is complex, which doesn't necessarily either have a beginning, a middle, and an end. And we know that recovery from something difficult is not linear, and sometimes recovery doesn't come. And I think for a medium that likes that narrative of we start here and we end here in a much better place, that can be quite frustrating. So I think talking about complex mental health issues, getting those stories told, can be quite difficult. And so I was really grateful, for example, like Channel 5, to deliver it to the BBC and Channel 5 are very different audiences, a different demographic. They serve different people and different audiences. And I was really pleased that we were able to do something for Channel 5 where every week we had a sort of 6 to 10 minute slot in the news, which is a busy place to get anything on, really, in the news, where we looked at something which is, let's look at how anxiety has manifested in this person and what they've done to manage it. Or, we were doing ADHD and oppositional defiance disorder. And we covered loads and loads of different topics and brought them to a new audience.
In a fascinating discussion with Professor Alan Young, head of the School of Academic Psychiatry at the Institute of Psychiatry, Psychology and Neuroscience, we explored mood disorders and learned how Alan first became interested in neuroscience.
Yeah, so really interested to see such an important topic that you've spent many, many years researching, is trying to uncover and understand mood disorders and its causes, and in particular bipolar disorder, where we focus on today, and also the treatment for bipolar disorder. But before we get into those details, Alan, what would be great is we're always keen to hear about people's journey in mental health research. So obviously I can detect, as I'm a brilliant scientist, your Scottish accent. So can we start with, tell us a bit about where you're from and how you got into psychiatry and mental health more broadly, and how you've got to now in, obviously, King's.
Well, thanks very much, Rory. So, I mean, I don't come from a medical family. In fact, I think I was the first person in my family to go to university. But at high school, I was good at sciences. And if you were good at sciences, they tended to want you to take a punt to medicine. And so I did. And so I got into Edinburgh University. And I actually, quite frankly, found the first few years quite boring. Perhaps that's a bit harsh, but, you know, certainly doing anatomy and so on didn't really excite me. But I really liked it when we got into the clinical years. And I did a sort of road test with all the subjects, because when you're a medical student, you do surgery, GP, you know, this, that, and the other. And I actually focused on the brain, actually, and thought that the bit I was interested in was the brain and brain disorders. And neurology just didn't seem very interesting or exciting. Because, well, essentially it wasn't, and there weren't many therapeutic prospects. But psychiatry, the Department of Psychiatry at Edinburgh at that point was really very strong. I'm not saying it's not strong now, but when my experience as an undergraduate was, it was quite inspirational. So I thought I would think about going into psychiatry and thinking about doing neuroscience research. And so that's how I ended up there. When I initially trained, I did my first postgraduate degree in brain imaging and schizophrenia, which was the 80s. Mm. And I did that with Professor Douglas Blackwood. And then I had the chance of doing a fellowship or going for a fellowship with the Royal College of Physicians of Edinburgh. And Guy Goodwin asked me if I wanted to do it in mood disorders with him. So I switched about 89, 90 into mood disorders. And I must say, I've found it personally a very rewarding field to work in. And I've worked in it in Scotland, England, North America. And I came to the Institute of Psychiatry, Psychology and Neuroscience about 10 years ago, and I set up the centre. One of the reasons for coming to King's, because I was at Imperial, I was chair of Psychiatry at Imperial, which of course is a fantastic university. But King's gave me an opportunity to do two things which were perhaps lacking elsewhere. One was very much get involved in the clinical side with the National Affective Disorders Service and set up a specialist service for bipolar disorder, which with colleagues I did. And also we established a master's in affective disorders. Now, lots of academics, look upon teaching as being perhaps something that's slightly less prestigious or rewarding than research. But in actual fact, I think there's a virtuous cycle between teaching and research. And I must say, having set up the masters and teaching on it and still teaching on it, I've learned a huge amount from having to communicate about my field to young, very bright students from all over the world. So I found it very rewarding.
No, I think the what you make there about whatever the virtuous cycle between teaching, especially I would argue postgraduate teaching and research, I think there is a real synergy. And I think it's great to see the university sector in some way now, I would say only in the last 5 or 10 years, starting to more reward more that more teaching informed research, I suppose, approach with the growth, I suppose, in master's programs. But I mean, as you say, it's always a balance. But I want to bring you right back. So did you tell me where you're from in Scotland, though? I don't think you did you?
Well, when I say where I'm from in Scotland, people have never heard of it. And when I say that, people then say, of course I'll have heard of it because I'm from Scotland. But I come from Clackmannanshire, and I come from a place in Clackmannanshire which is called Glendevon. And in actual fact, within that, I don't actually come from anywhere because my father, who's passed away, was a farmer, and so we, there wasn't a town or a village. We were a few miles. So I really come from nowhere. But the closest place that you can say I'm from is Glendevon or Clackmannanshire, and most people in Scotland have never heard of that.
I've never heard of Glendevon. Did you say Glendevon?
You never heard of Glendevon? It's got a lovely, and it was actually the lowland stronghold of the Campbells. And there's a nice castle there. You can go for a nice walk and look at it. It's very, and you can see, can't quite see Glasgow. You can see Fife, Edinburgh, the Lothians, the Forth from the top of the hills. So.
No, I know Clackmannanshire, but I don't know. So it's
the river Devon that goes through it.
Yeah.
The surrounding glen is Glendevon. So there you go.
Well, I'm glad we got to the bottom of that. I mean, because it was just curious you hadn't noticed it in there or hadn't mentioned it. But then, of course, then it's not part of your identity. Then, if you're, or less of it, part of your identity if you're saying you're from nowhere. So there, that is
Oh,
psychology.
no, I mean, I don't personally feel I'm from nowhere. I do feel I'm from somewhere, but I'm not from. I mean, the farm wasn't. It was a farm, so it wasn't a town. Our nearest town was maybe where I went to school first. Was about I think 3 or 4 miles away. So
Anyway, I digress there. So, Alan, so sorry about that.
Turning to children's mental health, we spoke to Professor of Child and Adolescent Psychiatry at the University of Glasgow, Professor Helen Minnis. Helen takes us back to her childhood in Scotland and describes how her early fascination with mental health shaped her career.
Again, I know about, I bet probably don't know as much as I'm going to learn today, but I know some of your history. So what we're really always keen on before we get into the nuts and bolts of the research that you do, and perhaps some of your thoughts around the priorities for mental health research, is get some sense of your journey in mental health research. So maybe where it all began, Helen. So
yeah,
take it over.
Well, I think my interest in mental health came from the fact that my mother was a social worker. She was a social worker in the west of Scotland in Blantyre, which at the time was just the Wild West, to be honest. And she used to talk confidentially about Mrs. X or Mr. Y, and I just found their stories absolutely fascinating, especially with regard to how they, people who were really struggling looked after their children. And it just really developed in me a real fascination with children's minds. But I didn't think I was a scientist. If you'd asked me at medical school who would be the scientist, I wouldn't have been on the list, because I didn't think it was kind of curiosity that was the main thing. Mm-hmm. And then I worked in Guatemala. I can tell you.
Hold on, rewind there for a second. Right? So, but how did the interest in medicine though? So how did you get to the
interest in medicine? So that was interesting because typical girl back then, I thought I wanted to be a nurse, and my godmother said, "You do realize that girls can be doctors?" And I was like, "Really?"
Okay.
And I was always interested in science, and I was also always interested in people. And I thought science and medicine, science and people really kind of rolled up quite nicely into medicine. I didn't have any doctors or scientists in the family, but I just had a kind of fire in my belly for being a doctor. For some reason. And to be honest, I don't think I would ever have studied at school if I hadn't had a fire in my belly about that. So that's what got me into medicine. But I didn't think I would be a scientist until I got really curious about abused and neglected kids in Guatemala. And I thought the only way that I can actually kind of, I suppose, slake the thirst to find out more is to write myself a research fellowship application, which I did. And I have to say, I probably was halfway through it before I began to realise that I did actually have the kind of attributes for being a scientist. So it was a bit of a surprise to me, to be honest.
Where did you train in medicine first?
I trained in medicine in Glasgow. I never wanted to stay in Glasgow. I think my dad's from the Caribbean. My mum was from Yorkshire. So I always wanted to travel. And because I ended up, Glasgow was the only place that would have me at the time. I did try to get into Queen's and Belfast, and they wouldn't have me. So
how dare they? How very
I know. So I literally left medical school with nothing but a travel bug. That was all I didn't know what my ambitions were other than being a doctor and traveling, because I felt really cooped up in Glasgow. So I was away from Glasgow for quite a number of years and just came back to actually train in child psychiatry.
And so when you left medical school, then did you go straight to Guatemala then?
Oh, I did my first year of house jobs.
Yeah.
Probably about 4/5 of the way through that year, my pal Lizzie phoned me up and said, "Have you got a job for next year?" And I said, "No." And she said, "Do you want to go to New Zealand?" And I said, "Yes," without hesitating, because it was going to get me out of Glasgow. So Liz and I went to New Zealand, worked there for a year. But I really wanted to work in a low-income country. I just had a curiosity about working somewhere really, really different from where I'd grown up. So I just kept asking around. And in New Zealand, I actually bumped into a woman who had worked in an orphanage in Guatemala. And she said, they're looking for a doctor. So I just wrote to them. And it was probably about a year before I got a response. And they said, "Yeah, you can come across and be the doctor. We're opening a clinic." So that was how that all happened.
And so how long did you spend in Guatemala?
I spent about 13 months in Guatemala, and then I trained in psychiatry at the Maudsley. And it's quite funny because everyone said that going to Guatemala would be an absolute career disaster. They were like, "Why taking time out of medicine. But I found out later that was what got me into the Maudsley, because everyone going to the Maudsley had stupidly brilliant CVs, which I didn't particularly. And I got really quite pally with the HR manager, and she said, you know, they were just like, oh yes, another PhD from Cambridge, yawn, another one from Oxford, Oxford, yawn. Oh, she works in an orphanage in Guatemala. She looks interesting. That's what got me in.
Yeah, and then so that's really when you started your journey then in mental health, specifically then the training in psychiatry, and then was the fellowship at the same time then?
No, so I did my core psychiatry training at the Maudsley, and that was a huge stroke of luck for me, because it was such a kind of research-focused clinical training. You know, they were really trying to get you to write and think about research as you're going along. So I started thinking about research, and I wrote a fellowship to get back to Guatemala, and it went to the Wellcome Trust, and the Wellcome Trust said, well, we quite like this idea, but you can't do it in Guatemala. It's never going to work. So it ended up being a randomized controlled trial of foster carer, basically of training of foster carers in Scotland.
Ah, okay. So I never realized that link then. So out of curiosity, why did they think it wouldn't work in Guatemala?
Well, it was actually, when I look back, you know, I knew nothing about research design, and I had what I thought was a great idea of comparing two orphanages, because the question that had come up for me was that at the time, this was in the 90s, in Guatemala, they really believed that you shouldn't talk to children about their difficult previous experiences.
Right.
And, you know, a huge proportion of the children in that orphanage had been street kids. They'd been abused. They'd seen other children being killed. I mean, it was terrible. You know, they had terrible experiences. And I come from a culture where children who'd experienced difficult, adverse childhood experiences, they were offered therapy. And I remember at first thinking, you know, they're not offering these children therapy. What, you know, I was probably quite patronizing in my view, in my head. I hope I didn't share those views. And then suddenly I realized that we didn't have any evidence for that in Britain either. You know, this was just a kind of axiom. We just believed that you should therapy children if they'd had difficult experiences. And the Guatemalans thought you should just close it down. And I thought, actually, we don't know who's right. So I had this, I thought, great idea of, in one orphanage, introducing a training for staff about how to talk to children about difficult experiences, and then the other orphanage not, and comparing the difference. And it was actually Professor Sir Michael Rutter, who was my head of department, and he looked at this proposal and he said, there's a flaw. That's an N of 2. I was like, no, these are huge orphanages. And so he explained that fundamental thing that if you just introduce an intervention into one environment, there could be lots of other reasons why that one changed. So it had to be a randomized control trial. And it took me a while to really believe that it really did. And it did become obvious that that absolutely couldn't have been done in Guatemala at the time. And by that time, I'd met my husband-to-be, and I'd kind of decided maybe I did want to move back to Scotland. And so it ended up being a randomized controlled trial of training for foster carers in Glasgow, in the central belt of Scotland.
And then what year was that then, Helen? Did you come back?
So I came back in 96.
96, okay. And obviously you haven't looked back since.
No. I mean, Glasgow's been great, and I'm so glad I came back to Glasgow.
Well, it's a great city, as we'll both agree, and Craig may not.
One day.
Where are you based, Craig?
I'm in London.
Well, I was in Camberwell for 5 years. I loved it.
Okay.
But I'm glad I live in Glasgow. That's all I can say. No offense.
Craig's
None taken.
Craig's just in the midst, he's just bought his first house. So he's in the midst of trying to sort that out at the minute.
Yeah.
It's another wonderful city.
Oh, it is. Of course it is.
I must tell you a funny story, because when I was in my welcome fellowship interview, you know, it's absolutely terrifying. There's like sort of 12 people there. I can't even remember who was on the panel because it was so terrifying. And these things are terrifying. And someone, you know, number 10 or something, he said, Dr. Minnis, it must have been awful working with those children in Guatemala. And I said, well, to be honest, now I live in Camberwell. And everyone just burst out laughing. And I just thought, oh no, I've just committed the ultimate crime. I've humiliated my interviewer, and I'll definitely not get this fellowship. Yeah. But apparently it was like 4:30, and they just were delighted at the light relief.
And you got it, so
I did get it.
So it's one you use all the time now, I assume, Helen, is it, to get your...
No, I think it probably was a bit of a risky strategy that just happened to be.
Indeed.
Finally, Dr. Josephine Breedfeld, Prudence Trust Research Fellow at King's College London, joined us to discuss early interventions for depression and anxiety in young people. Josephine shares what first drew her to mental health research and why prevention is so crucial.
Great. So we're just going to have a chat around stuff that you really interesting work you've been doing. And I think we'll probably focus on some of the young people's mental health stuff. But before we do, maybe we're always interested in taking us on a bit of a journey. And that journey is where you began. So you're Dutch, or you studied in the Netherlands, certainly. So you're going to tell us a bit about how you got interested in mental health, because I know you did an undergraduate psychology degree, and I know you've done whatever, master's like in mental health science, and a PhD as well. So just tell us a bit about your journey and what interested you initially on mental health.
Thank you. So I was first really interested in doing in doing medicine. So this was my original track, and then I had to take some exams, and then I realized actually I wanted to do. I kind of took psychology as a side university course, and I thought, well, I'm doing these exams to get into medical school, and I'll do psychology. And it just really captured me. So I just dropped my exams. I didn't look back, and I just went into mental health research, and have had kind of the fortune of having had so many different experiences as well. So I worked after my master's, I worked in mental health charity. So I worked at the Mental Health Foundation. And alongside that, I did my PhD. And then I moved back to the Netherlands. So that was all in the UK. And then I moved back to the Netherlands, where I worked to help set up a center in complexity science and urban mental health. And after that, I moved back to the UK again to take up my Prudence Trust research fellowship. So I've moved around a bit, which you probably will have seen.
But your PhD was cross-national as well. You had Simon Gilbody from York was one of your supervisors, as well as Claudia Botting and in the Netherlands.
Yeah.
So how'd that work then? So because I'm just looking at the grand title of your PhD, towards a new model of depression prevention. So curious, so tell us a bit about that.
So it was actually because part of my PhD, I was working at the Mental Health Foundation, and I did my PhD part-time alongside my role. And it was mainly, I guess we were wanting to get it set up I wanted to kind of do my PhD in the Netherlands to keep the Dutch link, but then I wanted to really kind of have a UK connection as well. And so Simon was kind of agreed to be a co-supervisor. I think what's really interesting in terms of the kind of grand scheme is, that's hopefully what we'll go on to a bit more, is what I actually realized in terms of the evidence for relapse prevention, and then contrasting that to primary prevention of depression.
Yeah. And so in terms of the discipline, what the PhD then spanned, a range of different disciplines. It was psychology, psychiatry, but broader than that.
And public health, public mental health. Yeah. So for example, one of the papers I worked on are what are the kind of public messages that you can include in public information campaigns. So, we say, exercise, or reach out to friends and feel connected to others, and focus on relationships. But what actually are the key messages that the public wants to include in kind of public mental health awareness campaigns? And there's quite a bit of debate about those as well, but at least we went to the public to ask what they wanted to see. So it even spans that as well.
And what were the key messages the public were keen to put in these campaigns?
We were thinking that maybe, trying to deal with your with thoughts and feelings and emotions, I guess coming from psychology, I think that would have come out as the strongest factor. But actually the top one factor was avoid illicit drugs. And the second one was kind of avoid being in debt. So kind of debt advice. So much more of the kind of, I guess, social, environmental factors rather than individual personal factors came out as being the top preferences of the public that they wanted to see included in awareness and mental health information campaigns.
And then, so did you then translate that knowledge into a campaign?
Yeah, so the nice thing was, in a way, that I was based at the Mental Health Foundation, and they were really keen on using research, so also other studies, and using that to inform their messaging. So this research then informed, for example, the how-to guides around mental health, the top 10 tips for mental health. So all the kind of things you might have seen or heard of in the kind of coming out of the Mental Health Foundation. So I'm glad it had this kind of route into practice.
Yeah. And so did you say you were doing your PhD at the same time as working at the Mental Health Foundation? And were they funding the PhD, or was it just coincidentally that you were employed there?
I was employed there. They weren't funding it. I was able to kind of take a little bit of my time out of my job. And at that point, I was also the head of the research department. So kind of having a little bit of time. And I was really trying to merge the kind of my research as part of my PhD together with the research at the Mental Health Foundation, so that there would be a bit of synergy. Otherwise, I would be ending up having to do kind of two things at the same time. So that's how I got it set up, which worked really well in a way that also the studies that I set up some of them came from a need from the Mental Health Foundation. Okay, so what do we know, for example, about primary prevention for depression in young adults? Because the foundation was interested in developing a program around prevention of depression in young adults. So we went and did a systematic review, and then that then helped to kind of inform what we did and didn't do as well.
Yeah, what we didn't do is probably as interesting as what we do, of course.